Good afternoon, everyone. Today's seminar is presented by Batch B1 on the topic of Tetralogy of Fallot. My name is Kiran Puri, and this seminar is conducted by the Department of Anatomy at the TNMC and BYL Nair Hospital, Mumbai. So, tetralogy of Fallot is a rare condition caused by a combination of 4 heart defects that are present at the time of birth. It happens in 1 in 3,000 live births, constituting 5 to 10% of all congenital heart diseases. The defects are pulmonary stenosis, that happens due to the narrowing of the pulmonary valve, as it can be seen here in this diagram, and right ventricular hypertrophy, that leads to the thickening of wall of the right ventricle, and overriding of aorta, which leads to the displacement of aorta over the ventricular septal defect, and the ventricular septal defect leads to the opening of the left and right ventricles, which leads to mixing of oxygenated and deoxygenated blood. Children with Down syndrome are often affected with tetralogy of Fallot and other congenital heart diseases. To understand this disorder better, I would like to call Khushi to present a clinical case.
Let's proceed with the case. A 29-year-old man with an illness-free past medical history presented with dyspnea. A week before his presentation, he started to experience exertional dyspnea with moderate activities associated with atypical pricking chest pain. Vitals were taken and they were normal apart from the blood pressure, that is 150 on 90 mmHg. Physical examination revealed elevated jugular pressure. High systolic ejection murmurs were best heard at the left upper sternal border. Blood tests were conducted and they were normal. Electrocardiogram was exhibited a right bundle branch block that could be detected from the precordial lead V1 by the M pattern, and right ventricular hypertrophy. The chest radiograph revealed a normal appearance of heart. Electrocardiogram of the patient showed membranous ventricular septal defect, severe pulmonary valve stenosis, severe right ventricular hypertrophy with tricuspid valve regurgitation and overriding aorta. So all these records reveals that the patient has tetralogy of Fallot. Now the embryological development of the heart will be dealt by Shubal. Thank you.
Now, at the cranial end, at this cranial end of splanchnopleuric plate of mesoderm, two heart tubes are developed, which unites to form single heart tube. Then, after it develops into various parts, which are bulbous cordis, primitive ventricle, primitive atrium, and sinus venosus, of which bulbous cordis is differentiated into three parts: the truncus arteriosus, the conus, and the posterior 1/3 part. All the structure upon various folding give rise to the mature musculature of the heart. Internally, the development of the interatrial septum is done by septum primum and then septum secundum, foramen of ovale. The closure of foramen ovale is due to the pressure changes because of the ventricular filling of the atrial filling of the blood, which leads to the development of a right atrium and the left atrium. Similarly, this diagram depicts the development of interventricular septum, which leads to the development of right and the left ventricle. The interventricular septum is composed of bulbar or coronal part, the membranous part, the muscular part, of which the membranous part and the muscular part fuses to form the right ventricle and the left ventricle, failure of which leads to the ventricular septal defect. For the further anatomy of the heart, I would like to call Aishwarya Kulkarni.
To understand the tetralogy of Fallot, let's take a quick overview of the anatomy of the heart. Heart consists of the right atrium, right ventricle, the left ventricle, and the atrium. The right side of the heart contains deoxygenated blood, and the left side of the heart contains oxygenated blood. In the defect seen in tetralogy of Fallot, which is the ventricular septal defect, the mixing of blood occurs between the left ventricle and the right ventricle. Also, we can see the pulmonary trunk, which carries deoxygenated blood from the right ventricle to the lungs. The aorta carries the oxygenated blood from the left ventricle to parts of the body. Overriding of aorta is also seen in tetralogy of Fallot. Uh, Also, here we can see the pulmonary valve, which guards the pulmonary trunk. It prevents the backflow of blood from into the ventricle. So the stenosis of pulmonary valve is also seen in tetralogy of Fallot. Similarly, these are the valves which guard various chambers of the heart. Uh, Now I would like to call Ipsita to present the various defects in tetralogy of Fallot.
So, as discussed in the case, there are four defects in the tetralogy of Fallot. The first is pulmonary stenosis, right ventricular hypertrophy, overriding of aorta, and ventricular septal defect. I will be covering the topic pulmonary stenosis. So, the pulmonary stenosis is a heart valve disorder that includes defect in the pulmonary valve. It can be congenital or acquired in the adult life. It can be of three types: valvular, supravalvular, and subvalvular. If the stenosis occur at the main artery, then it is called supravalvular. If the stenosis occur in the infundibulum part, then it is called subvalvular pulmonary stenosis. Now the causes. The main causes of the pulmonary stenosis is overriding of aorta, overgrowth of heart muscles. Congenital stenosis mainly occurs due to defect in the gene. For example, in Williams syndrome, that is a rare genetic disorder, uh, a pulmonary stenosis is seen in the patient. Pulmonary valve contains three leaflets or cusps that become thickened and glued together along their commissures, which lead to a condition called valvular pulmonary stenosis. In, uh, if rubella infection occurs during the pregnancy, then pulmonary stenosis can be seen in the child. A further heart murmur is heard in this case because of the choppy blood flow across the narrowed pulmonary wall. Echocardiogram, it can be diagnosed by the echocardiogram and electrocardiogram. Also, MRI and CT scan can also be used for the diagnosis purposes. Dyspnea, increased exercise intolerance is seen in this condition due to obstruction of blood because of the narrowed pulmonary wall. Less blood reaches to the lungs. So to compensate this, the heart valve, the right ventricular heart muscle gets thickened, and this leads to a condition called right ventricular hypertrophy. To explain this topic further, I would like to call Janvi. Thank you.
Good afternoon. So I'll be proceeding with right ventricular hypertrophy. As you can see both the images, in the first image it shows the normal heart. This is the right ventricular wall of the normal heart, and this is of a heart with right ventricular hypertrophy. As you can observe here, there is a massive thickening of the walls and the cardiac muscle in the second picture. So we'll see why it is caused and what it leads to. So right ventricular hypertrophy is caused usually by pulmonary stress. When presented exclusively, it is caused due to a severe lung defect or disease. But when presented congenitally, it is usually due to pulmonary stenosis, as in the case of tetralogy of Fallot. So in this case, due to pulmonary stenosis, there is a lot of back pressure coming on the right ventricle due to the blood, and hence the heart muscle has to exert immense amount of force and stress to pump the same amount of blood towards the lungs. This causes the hypertrophy of the walls of the heart. Now, the effects of RVH, it causes the loss of elasticity of the cardiac muscle of the right ventricle, and because of this, the heart loses the ability and it pumps lesser and lesser blood to the lungs each time, which compromises the oxygen capacity of the entire body. It also causes tricuspid regurgitation because of the force with which the right ventricle is pumping the blood. It also increases the overall blood pressure. We'll be looking at how to diagnose right ventricular hypertrophy as well. It can be easily diagnosed using ECG as well as the radiology. With X-ray, the X-ray part of it will be explained later. I'll be completing the ECG here. As you can see, the normal ECG, in the lead 2, the PQRST waves are clearly very predefined. Whereas in the case of right ventricular hypertrophy, you can see a highly elevated R wave, which is more than 7 millimeters. Also in V2 and V3, we can observe a depressed ST segment as well as an asymmetrical T wave. So these three are very important in diagnosing right ventricular hypertrophy. Apart from this, we can use the features of right axis deviation, which is also observed in right ventricular hypertrophy. So this causes a lot of depression of the S wave here, as you can see in this case. This is now further the third defect is the overriding of aorta, which will be explained by my colleague Ishita Thupre. Thank you.
Thank you, Janvi. Overriding of aorta is a congenital defect in which aortic valve enlarges and appears to originate from the right ventricle rather than the left and overrides the ventricular septal defect. The degree of overriding is quite variable, with 5 to 95% times the valve being connected to the right ventricle. Now, there are mainly two types of overriding. It may be either complete overriding, in which the aorta completely overlies the ventricular septal defect, or partial overriding, in which only a part of aorta overrides the ventricular septal defect. The patients with overriding aorta may experience pain in the chest, upper back, shortness of breath, dizziness, or heart palpitations. And the main cause of this is alcoholism, diabetes, rubella, lack of nutrition, advanced age over 40 of the pregnant women. Now, normally 1% of babies are born with heart abnormalities at the time of birth, but out of which 10% of them have tetralogy of Fallot with overriding of aorta. Now, due to poor oxygenation of blood resulting from the mixing of the blood, the babies with an overriding aorta develop TET spells, in which the cyanosis occurs, which is the bluish discoloration of the skin, nail beds, lips after feeding or crying. Now, I would like Rutuja to explain the next topic, ventricular septal defect.
Now, I will be discussing about the ventricular septal defect. Ventricular septal defect is an opening in the wall of heart separating the two chambers of the heart. It is one of the most common congenital heart defects. Naturally, in normal development, the wall between the two chambers closes before the fetus is born, so that by birth, oxygen-rich blood is kept from mixing with the oxygen-poor blood in the right ventricle. But in case of a child with VSD, due to the higher left ventricular pressure, the oxygen-rich blood mixes with the oxygen-poor blood in the left ventricle and then goes to the lungs. These changes may increase the blood pressure in the lungs and require the heart to work hard to pump the blood. The patient with VSD will have less oxygen going to the rest of the body and will start to develop cyanosis. Large defect result in significant left to right shunt and cause dyspnea with feeding and poor growth during infancy. Let's take an example. As we all know, the Madhugala, famous actor, died due to ventricular septal defect. Now, to discuss about the embryological basis of VSD, I will pass over to my colleague Aditi.
Thank you, Rituja. As we all know, ventricular septal defect basically means that there is a gap in the interventricular septum. To understand how this gap forms, we need to understand the embryology of ventricular septal defect. The interventricular septum has three components as discussed earlier: the muscular, the inlet, and the outlet. The muscular interventricular septum forms by the proliferation of tissue upwards from the apex of the heart, whereas the membranous interventricular septum is formed by the downward growth of the aorticopulmonary septum towards the muscular interventricular septum and the posterior inferior proliferation of the tissue. Fusion of the membranous and the muscular parts of the interventricular septum forms the complete interventricular wall. Ventricular septal defect occurs in the failure of this fusion. This results to a gap between the right and the left ventricle, which leads to the shunting of blood and the passing of mixed blood. The size of the gap may vary. There's often no clear cause of why this happens. As we can see in this picture, over here is the normal heart and the complete interventricular septum, whereas here is the ventricular septal defect, which leads to the mixing of blood from the oxygenated compartment and the deoxygenated compartment and the passing of mixed blood to the lungs. Now, to understand the clinical manifestations, I would like to call my colleague Shara.
So first clinical manifestation is cyanosis, that is nothing but the bluish discoloration of skin, nail bed and lips. It is due to the decrease in oxygen concentration in the blood causes, which ultimately leads to a range of symptoms like fainting, failure to gain weight, feeding difficulties and tiring easily during playing. As we see in the image of a little child, there is a peripheral cyanosis around the nail beds and central cyanosis around the lips. The third clinical manifestation is a heart murmur that is heard at the left mid and upper sternal border. It is mainly due to the pulmonary stenosis. The fourth clinical manifestation is the TET spells or hypercyanotic spell. It is occurred in the severe conditions of tetralogy in infants. It is nothing but the deepening of cyanosis or suddenly developing a deep blue skin after crying or feeding of baby. It is characterized by rapid and deep breathing, that is hyperapnea, deepening of cyanosis, decreased intensity of heart murmurs. Treatment for this is hold the child in knee chest position. As we see in the image, after holding a child in knee chest position, there will be the kinking of femoral artery and femoral veins, which leads to decrease in the pulmonary artery resistance and increase in the systemic vascular resistance, which leads to enter in the blood in the pulmonary artery and decrease the effects of the TET spells. For further diagnosis is presented by Shraddha.
Thank you, Shardul. So I'll be discussing the diagnosis of the tetralogy of Fallot. First is the history collection. Next one is the physical examination, which includes the cyanosis, that is the infants turning blue, as we can see in this image, that is called as the TET spills or the hypercyanotic spills. Next is the clubbing, as we can see in this image, the clubbing of the fingers is seen in this figure, that is the nail beds become rounded. Pulse oximetry can also be done. This is a bedside test for measuring the oxygen saturation. Next one is the X-ray examination. As seen in the radiograph, there is a boot-shaped heart seen due to the overriding of aorta as well as the right ventricular hypertrophy. Hence, there is the upward cardiac apex is seen here. After the X-ray diagnosis, auscultation can also be done. It is in the auscultation part, different parts are there where we can auscultate and different heart murmurs or the whooshing sound is heard there. At the left sternal border as well as at the upper right sternal border, where the systolic murmur as well as diastolic murmurs can be heard. and we can diagnose the tetralogy of Fallot. Next one is the ECG. As we can see here, there is the long R wave or the long R wave and the depressed ST segment, and it is due to the right ventricular hypertrophy. It can also be diagnosed as the tetralogy of Fallot. Cardiac CT scan can also be done. It can show the overriding of aorta, ventricular septal defects, as well as the right ventricular hypertrophy, as we can see in this CT. After the CT, cardiac MRI can also be done. It also shows the right ventricular hypertrophy, pulmonary stenosis. Echocardiographic can be the best diagnosis for the tetralogy of Fallot. Here we can see the parasternal long axis view is seen of the echocardiogram. Here we can see the ventricular septal defect as well as the overriding of aorta. Cardiac catheterization can also be done here. The catheter is drawn into the heart of the baby, and catheterization is done for the blood pressure as well as oxygen saturation for the heart chambers as well as the artery. The low systolic pressure in the right ventricle as well as left ventricle, and the low systolic pressure in the pulmonary artery. It is the diagnosis for the tetralogy of Fallot. Next, I will be discussing about the radiology of the tetralogy of Fallot. This is a radiograph. As we can see, there is a typical boot-shaped heart is seen here. There is an upturned cardiac apex, which is also called as a core and sabot, and the right ventricular hypertrophy is seen here, and the overriding aorta can also be seen. The right ventricular hypertrophy is seen, and in the lungs we can see the pulmonary oligemia. It is due to the pulmonary stenosis, because of which the vascularity as well as the blood flow to the lungs it decreases. So this is all about the radiology as well as the diagnosis. Now I will call Nidhi for the treatment of the tetralogy of Fallot.
Thank you, Shweta. Treatment first in the emergency condition, cyanotic spell. We can perform the knee chest position, in which we can see in this figure how the baby is placed in the knee chest position, and in this manual we are performing because the blood pressure increases, so the blood flow to the lungs also increases, and that reduces the cyanosis. The second is the oxygen. Oxygen is provided through the face mask to reduce the cyanosis and increase amount of the oxygen in the blood. Beta blockers such as a propranolol, and vasopressors such as the catecholamines like epinephrine and norepinephrine that constrict the blood vessels, and resistance increases, so therefore blood pressure increases and more blood reaches to the peripheral tissues. Surgical management includes the temporary as well as complete repair. The shunt are the temporary repair in which the tube is placed. These are the operations which are designed to reduce the cyanosis. The tube is placed between the branch of the aorta or the aorta and between the right pulmonary artery. So the more blood reaches to the lungs, and therefore the amount of the oxygen in the blood increases. And the shunt operations are the Blalock tossing operations, in which the connection is made between the aorta and the right pulmonary artery. Port shunt, in which the connection is made between the descending thoracic aorta and right pulmonary artery. The third one is a water shunt, in which the connection made between the ascending thoracic aorta and the left right pulmonary artery. And the fourth one is the total correction, in which the ventricular septum is closed and the pulmonary stenosis is open, that allow the blood flow to the lungs. I would like to call the Vaishnavi to further information about post-operative complications.
So we are almost at the end of the topic. My friends have covered all the topics, and now we will discuss about the post-operative complications of the tetralogy of Fallot. First is the risk of the sudden cardiac death. This is due to the pulmonary regurgitation, and it is also related with the right ventricular hypertrophy. Second is the residual of the ventricular septal defect, which is almost insignificant in the surgeries, and this is due to the suture disruption or the patch dehiscence. Bundle branch block. This is due to the disruption of right ventricular conduction system during the right ventriculotomy. Pulmonary regurgitation is associated with the right ventricle enlargement. Pulmonary regurgitation, it is an important determinant of the late morbidity and mortality. Aneurysm, out of which thoracic aorta aneurysm is the most common, and this is due to the increased volume overload of the aorta and due to the right to left shunting. Leaking of the heart valves, this which causes the murmurs. Ventricular outflow tract obstruction leads to this, and which occurs in the pulmonary stenosis. Pulmonary embolism, as the patient has physical inactivity during the period of treatment. There is polycythemia, which further leads to hyperviscosity and causing increased thromboembolic events. Life expectancy is increased to about 80 to 90% after the post-operative management, but still these complications are occur. The figure shows the pulmonary regurgitation or the pulmonary stenosis. Here it shows the atrial or the ventricular arrhythmias. Arrhythmias are one of the major cause which cause the post-operative deaths. Aortic dilatation, the residual of the ventricular septal defect, and the right ventricular dysfunction and the left ventricular dysfunction, which further leads to the ventricular hypertrophies. Now I would like Kiran to conclude the topic, the tetralogy of Fallot.
Good afternoon. We are towards the end of the seminar. I'd like to thank you all for patiently listening. So the defects that has been discussed so far affect the structure of heart, causes the oxygen poor blood to flow out of the heart and to the rest of the body, causing cyanosis. This disorder can be diagnosed within the first few weeks of life, either by a loud murmur or cyanosis. Babies with tetralogy of Fallot needs a corrective surgery. It can be done via shunt operation, which is temporary, or it can be done through a complete repair, which has to be done early in life. People with tetralogy of Fallot needs a regular doctor's checkup for the rest of their lives and may have restricted activities throughout their lives. So thank you. This would be all from our side. Any kind of constructive feedback is welcome in the chat box, and thank you.
Heartiest congratulations to the students of B1 batch who have presented this seminar under the guidance of Dr. Sanjay Mishra sir on the topic of tetralogy of Fallot. It was really fabulous. You explained the embryology very nicely and you very nicely coordinated it with symptoms and treatment. Overall, it was a very nice experience, and the explanation of embryology of the heart was really fabulous. Everybody was very confident. You spoke very nicely. The PowerPoint was really power packed, and I would highly recommend that any student who wants to study the congenital anomalies of heart, development of the heart, should refer to this particular seminar presentation which we are uploading on YouTube. Please do watch it again and again. And once again, congratulations to all the students of B1 batch who have presented this nice seminar on tetralogy of Fallot.